All. So we'll discuss today one of the important case, that is meningitis. So lots of questions are expected in and around meningitis, encephalitis, differentiation, imaging modality, choosing an antibiotic, isolation precaution, duration of antibiotic, steroid. So when to consider doing a lumbar puncture before imaging, after imaging. So all these things we are going to discuss maybe in another 35 to 45 minutes. So with the backup of evidence and that of the experience. So here we go with the case-based discussion on meningitis. So 24-year-old male is brought to emergency department by his hostel friends with high-grade fever, headache, photophobia, and altered sensorium for the past 12 hours. So he is a university student, so staying in a shared hostel room. So initial vitals and bedside assessment. So his GCS was E3 V2 M5, so 10 by 15. So blood pressure is 100 by 60. Heart rate tachycardia 122, respiratory rate 28 per minute, saturating around 92% on room air. So temperature is 39.8 degrees Celsius, sugar is 108. So his capillary refill time is 3 seconds. We got pH in the emergency department, means ABG in the emergency department. His pH is 7.32, PCO2 is 32, PaO2 75, bicarb is 18, lactate is 2.9. So young male who had fever, headache, photophobia, altered sensorium, tachycardia, borderline blood pressure, GCS is 10, so temperature is high, so there is high lactate with a pH of 7.32. How you are going to proceed? So what you want to do for this patient in the next step? Okay, so obviously like any other patient whom you are going to receive, so you always tell airway, breathing, circulation. So airway, so patient is having a GCS of 10 by 15, so there is a borderline for airway protection. Patient is drowsy, no active vomiting or convulsion history. So for now airway appears maintainable. So we have an indication for airway protection when we have a GCS somewhere around less than 8. So prepare for early intubation if there is a worsening up of the GCS of less than 8, or if signs of raised intracranial pressure appears on the go, means sudden pupillary asymmetry, new onset of focal neurological deficit, or further drop in GCS. These are some of the indication for telling that there is an increase in intracranial pressure. So then you might require to go for the airway protection. So coming to breathing, is breathing at a rate of 28 per minute, saturating 92% on room air. So maybe we can start oxygen via non-rebreathing mask or a simple face mask. So maintain like saturation somewhere around 92 to 94%. So on examination, like rule out is there any like ongoing pneumonia because patient is having a fever. Okay. So like any crepitation, consolidation is there, or any aspiration is there because of the altered sensorium. So repeat ABG after initiating some sort of therapy with oxygenation and all. So in terms of circulation, is BP is 100 by 60, heart rate is 122, capillary refill time is 3 seconds, so which is just a borderline. If it is more than 3 seconds, that is what we have a cutoff for peripheral hypoperfusion. So there might be some sort of early shock, tachycardia, borderline blood pressure with a borderline capillary refill time. So most commonly with the background of fever, with all this clinical manifestation, if at all patient is going to have a shock, it's going to be distributive shock, that is a septic shock. Okay, so maybe secondary to meningitis if our diagnosis is consolidated. So immediately, so take like IV access, preferably 2 access if patient is going to require fluid resuscitation and some vasopressor support. So take the blood culture, start fluid at least 10 to 20 ml per kg, like how we manage the sepsis with a crystalloid. So monitor for the response to the initiation of the fluid. So monitor ongoing mean arterial pressure, heart rate, urine output. So repeat the lactate, that is the ABG, in the next 2 to 4 hours. So consider early vasopressor, there is norepinephrine. If MAP is not going to be improved, so beyond 65 with the fluid alone, hand in hand with the fluid, so you can start a patient on norepinephrine. So that's about the circulation. So examine for neurological disability. GCS is 10 by 15. Add a history of fever, photophobia, and altered sensorium. So full neurological examination is very essential, like pupillary asymmetry, reaction to light, So muscle tone, reflexes, neck stiffness, so bedside fundoscopy. So some examiner may be very particular. So when you have a suspicion of meningitis, so we are not narrowed down toward the bacterial meningitis, they might ask, have you done the fundoscopy? At least you should make an attempt. Okay, can I do fundoscopy? Our fundoscopy is available, so that you should keep in your mind. So if any signs of riser ICP, so then intubation may be required prior to imaging a lumbar puncture. So document GCS every hourly. Exposure, look for rashes, very, very important. Okay. So because meningococcemia can have typical rashes, signs of any neurological trauma, then it may be some sort of trauma with exposure of the brain tissue or meninges with the meningitis. So pressure areas look for. So monitor the temperature. Already patient is febrile. So start them on antipyretic. So surface cooling. So aggressive maintenance of the normothermia is very important. So insert Foley's catheter. Monitor the urine output because is having a borderline GCS. So baseline lab you can send like CBC, C-reactive protein, procalcitonin may or may not be required. If your diagnosis is based on clinical examination, don't use the procalcitonin for diagnosis of the sepsis. Very, very important. So we have prorata trial. So procalcitonin you can use for de-escalation, not for diagnosing. So renal function test, liver function test, coagulation, blood glucose. Okay. So CT brain before LP since the patient is having a GCS of less than 10. So this is, you can tell in the initial, like your monitoring and that of the management pathway itself, you can comment on the CT, or you can wait for examiner's question. So you might ask down the line, you want like imaging first before the LP, or you will proceed with the LP. So you can wait for that question also. So what are the differential diagnosis in a patient with a febrile encephalopathy? Young patient, fever, altered sensorium, photophobia, tachycardia with a GCS of 10. Okay, with borderline blood pressure, with febrile ongoing fever. So what are the differential diagnosis? So remember, so we have a infective etiology of the CNS. So okay, so our systemic infection or it's a non-infective neurological condition. When it comes to CNS infection, febrile encephalopathy, acute bacterial meningitis, so they have fever, neck stiffness, altered sensorium, photophobia. So how to differentiate? Send the CSF. So it will be pleocytosis, neutrophilic predominantly, low glucose, high protein, high lactate. Okay. So viral meningoencephalitis, particularly HSV, fever, seizure, focal deficit, behavioral changes. So CSF, lymphocyte predominance, normal sugar. So we can go for PCR for like seeing, like diagnosing the HSV with the HSV PCR. So TB meningitis, usually the onset is subacute. So cranial nerve palsy, particularly sixth nerve involvement. So there is a history of low grade temperature, loss of weight, loss of appetite may be there. So in a TB patient, or they might be having a so concurrent pulmonary TB also. CSF, lymphocyte predominant, so high protein, low glucose. Okay. So AFB stain may be positive. So you can send so TB PCR, CBNAT, okay, TrueNAT and all those things. Fungal meningitis. So we will have a immunocompromised patient history, particularly cryptococcal. They usually manifest with headache, rising intracranial pressure. We can diagnose with a CSF India Inc. So like cryptococcal antigen, CSF fungal culture, all those things you can do. So other systemic infections, so they can also cause febrile encephalopathy, particularly when patient is having a severe sepsis. They will have high grade fever, hypotension, encephalopathy. There is usually no focal deficit. If it is a septic encephalopathy, normal CSF, okay, we have some systemic source like maybe pneumonia, severe pneumonia can have encephalopathy. So that it looks like a febrile encephalopathy. Cerebral malaria, so recent travel history to endemic area, convulsion they can have. So we can do malarial rapid antigen test, peripheral smear. Usually they have a so transaminitis, thrombocytopenia and all. So non-infective neurological conditions, autoimmune encephalitis, usually they are young adult. So they will have a behavioral changes. They can have convulsion. So CSF mild lymphocytosis. So anti-NMDA receptor antibody, anti-VGKC antibodies we can diagnose for autoimmune encephalitis. Subarachnoid bleed. Okay. So sudden headache, severe life-threatening headache. Okay. So we call it as a thunderclap headache, photophobia, neck stiffness. So CT shows hyperdense sulci. that is subarachnoid bleed, so xanthochromia in the CSF analysis. So toxic or metabolic encephalopathy, usually they have a precedent like drug overdose, liver or renal failure, metabolic acidosis, which may be high anion gap metabolic acidosis, normal CSF, no meningeal irritation signs. So CNS vasculitis, so usually they have headache, cognitive dysfunction, ischemic stroke. MRI with vessel wall imaging is the diagnostic modality. So usually they will have some connective tissue problem with ANCA, okay, so ANA positivity. So this is a fantastic table, so you can remember for all sort of your exam and the bedside practice also. So what are the clinical features suggestive of meningitis and history and examination? So in our patient, so patient had a history of fever, headache, photophobia, vomiting, neck pain, altered sensorium, so convulsion. So an examination, neck stiffness, so Kernick sign, Brudski sign, sign of raised intracranial pressure, focal neurological deficit, so petechial rash in meningococcal meningitis, papilledema, cranial nerve palsy, particularly in like TB meningitis. So these are some of the clinical features. So we might not get all classical triad of meningitis in any particular patient, but you should have a differential diagnosis with all these mix and match of the clinical manifestation. Very, very important. Okay. So these are some of the symptoms as I already told. Like, so don't think in all patient you are going to get Kernick center of the Brudski sign. So examiner might ask, so hardly in less than 20-30% of the patients will get so positive Kernick center of the Brudski sign. What exactly we'll do? So in Kernick sign, so patient is in supine with a hip flexed 90 degree, so knee cannot be fully extended. Okay, so you will start having the meningeal irritation and that of the pain. So Brudski's sign, okay, so neck rigidity. So when you do a passive flexion of the neck, okay, which causes flexion of both legs and thighs, so that is because of the neck rigidity. Okay, so Kernick sign, so knee extension is painful. So Brudski's sign, so neck flexion leads to knee flexion. Okay, so both hip and knee are flexed if neck is being flexed. So bend the neck, hip and knee are going to be flexed. So these are some of the mnemonics which you can remember for Kernick sign and that of the Brudski sign. Examiner might ask you to demonstrate these signs. So it may be difficult in a ventilated or critically ill patient, but if patient is not so sick, he might ask you to demonstrate. So these are the clinical features which I already discussed. So in a patient with a meningitis. So how will you investigate? So you are narrowing your diagnosis towards meningitis. How you are going to investigate a patient so with this background with a young with fever, altered sensorium, photophobia with a GCS of 10. Okay. So basically these are all investigations which we can consider, but you need to answer which are relevant to that patient. So full blood count, so neutrophilia suggestive of bacterial infection. Okay, serum glucose often low, which is going to be so which also helps in interpretation of the CSF glucose correlation. So electrolyte urea and creatinine, so it helps in assessing the complication and so it gives an idea about the fluid management. Coagulation studies, okay, to assess for the complication. So culture, so even though positivity is around 40 to 90% depending upon the organism, it is mandatory to send the blood culture. So inflammatory markers, as I told, so procalcitonin, don't use it for diagnosis. So usually they are elevated in bacterial infection, but not mandatory. Okay, so neither can establish nor exclude the diagnosis. That is very, very important. So procal or CRP is not a standalone criteria for diagnosis. Okay, so when it comes to CSF examination, so protein and glucose, gram stain, microscopic culture sensitivity. So strep pneumoniae, which is a gram positive cocci. So Neisseria meningitis, which is a gram negative cocci. H influenza, again it is a gram negative rod. So latex agglutination, so depends upon like it is a rapid test, so it is not 100% specific or diagnostic. Okay, so latex agglutination depends upon lab availability, so it helps in Neisseria like meningitis, strep pneumoniae, Haemophilus influenza type B, E. coli, and group B streptococci. We can go for the latex agglutination. So again, PCR, which is rapid, good sensitivity. So like we have a very improved techniques of PCR, multiple PCRs and all. So it depends upon again the lab availability. We can have PCR for Neisseria, strep pneumonia, H influenza, okay, Listeria monocytogenes, HSV, okay, to assess for the complication. So culture, so even though positivity is around 40 to 90% depending upon the organism, it is mandatory to send the blood culture. So inflammatory markers, as I told, so procalcitonin, don't use it for diagnosis. So usually they are elevated in bacterial infection, but not mandatory. Okay, so neither can establish nor exclude the diagnosis. That is very, very important. So procal or CRP is not a standalone criteria for diagnosis. Okay, so when it comes to CSF examination, so protein and glucose, gram stain, microscopic culture sensitivity. So strep pneumoniae, which is a gram positive cocci. So Neisseria meningitis, which is a gram negative cocci. H influenza, again it is a gram negative rod. So latex agglutination, so depends upon, like, it is a rapid test, so it is not 100% specific or diagnostic. Okay, so latex agglutination depends upon lab availability, so it helps in Neisseria, like meningitis, strep pneumoniae, Haemophilus influenza type B, E. coli, and group B streptococci. We can go for the latex agglutination. So again, PCR, which is rapid, good sensitivity. So like we have a very improved techniques of PCR, multiple PCRs and all. So it depends upon again the lab availability. We can have PCR for Neisseria, strep pneumonia, H influenza, okay, Listeria monocytogenes, HSV, CME, enterococci, tuberculosis. So all these things we have a PCR. Lactate, so routine use not currently recommended from the guidelines, but many studies are showing some clinical utility. We'll discuss later. So imaging, okay, we have particular imaging where we need to do prior to LP. Again, we'll discuss all those things. So others like PCR on blood or urine. So it is useful if CSF is not obtainable. If you are able to get a CSF, it is fine. If it is a dry tap, then you can do the PCR in the blood or urine also. Very, very important. So what are your initial investigation in this patient? So we discussed clinical features, investigations, what we can expect to send in this particular patient. So what investigation we got in our young gentleman? So his WBC is 22,000 with a neutrophil predominant, CRP is 84. So blood culture, two sets we sent before giving the antibiotic. So LFT, RFT electrolyte, mild hyponatremia is there, sodium is 128, creat is 1.1. So ABG shows mild metabolic acidosis, lactate is 2.9. So X-ray is clear, coagulation profile, we got it as INR of 1.2. Okay, so these are, so our investigation, WBC is very high, it is 22,000. Okay, so in this patient, would you do lumbar puncture immediately? So what are the indications for imaging before LP? Okay, so as I told, GCS is 10, we prefer, okay, we'll get a imaging prior to LP. So but in general, what are the indications? That may be your next question for imaging before the LP. Okay, so in this patient, definitely, so CT required before LP because patient is having a GCS of around 10. So possible raised intracranial pressure is having tachycardia, borderline blood pressure. So better to go for a imaging before LP. So otherwise, so CT or an imaging before LP include, indication include immunocompromised state. So HIV, AIDS, or immunosuppressive therapy, transplant patient. So if they have a CNS disease history like a space occupying lesion, so previous stroke or any focal infection documented, so then do imaging. So new onset convulsion within 1 week of presentation. So if the convulsion happened in the last week, better to go for imaging. So if patient is having papilledema, do imaging. Altered mental status, better to go for imaging. Focal neurological deficit, like, so they have a gaze palsy, visual field abnormality, face, arm or leg weakness, or aphasia. So these are the classical indication for imaging before the lumbar puncture. Very, very important. Okay. So in our young gentleman, we got this CT, interpret the CT. What's happening in this CT? Okay. What is the interpretation? Very, very important. Okay. So generalized abnormal leptomeningeal enhancement is there. So no basal cistern enhancement, so that it helps in ruling out the tubercular meningitis. No focal enhancement in brain intraparenchymal lesion. So nothing is visible. So there is a prominent, so third ventricle as well as the temporal horns of the lateral ventricle with early generalized effacement of the cortical sulci. So there is a effacement of sulci. So definitely there is some concern about little bit like raised intracranial pressure. So with all this clinical means image manifestation in our patient. Okay. So we done the CSF subsequently after excluding any major contraindication for CSF. So it appears turbid. Opening pressure is around 290 millimeters of water. WBC is like 1800, 90% are neutrophils. Protein is 2.3 gram per liter, glucose is 12, with a paired serum glucose is 110. So CSF lactate we got 6.8, LDH is 152. So grams time, okay, it is a gram positive, diplococci is seen. We got some clarity here, okay, what we are dealing in our young gentleman. So interpret this CSF, what is the likely diagnosis, okay. So obviously, so this is the bacterial meningitis with a high opening pressure, neutrophilic pleocytosis, 1800 cells with 90% neutrophils. So low glucose, high protein, okay, high CSF lactate and a gram positive diplococci, so which move towards the bacterial meningitis. But we need to isolate what organism exactly, okay. So how do you differentiate meningitis and encephalitis clinically, CSF wise? Okay. So very, very important. So I told some differential diagnosis for different meningitis, bacterial, viral, and that of the TB meningitis. But meningitis and encephalitis, how we are going to differentiate. So two, three important things are if patient is having a focal neurological deficit, convulsion history, cranial nerve involvement. So keep in your mind, it may be encephalitis also. Very, very important. Okay. So if you see, so primary pathology in meningitis, it is the inflammation of the meninges. So inflammation of brain parenchyma in encephalitis. Acute onset, hours to days in meningitis. So acute to subacute, hours to days in encephalitis. Fever, severe headache, photophobia, neck stiffness. So classically, you can see the mix and match in meningitis. Fever, altered sensorium, behavioral changes in encephalitis. Usually, like level of consciousness preserved until the late in meningitis. So it's going to be impaired early in encephalitis patients. So neurological signs like Kernicks-Brudski's nuchal rigidity you can find in meningitis. So focal neurological deficit, aphasia, cranial nerve involvement is common in encephalitis patient. Okay. So seizures less common in meningitis. Encephalitis is more common, often in the early phase. So skin findings like petechial purpuric rash, particularly meningococcemia, so possible in meningitis. Usually in encephalitis, skin findings are absent. So if you see the CSF findings, okay. So as I already told, in meningitis there is a neutrophilic pleocytosis. So lymphocytes in viral and TB meningitis. So in encephalitis, usually it's going to be lymphocytic, and the counts are somewhere between so 50 to 1000, but it's going to be 1000 to 5000 in meningitis. So protein markedly elevated. It is 1 to 5 gram per deciliter in meningitis, which is mild or moderate elevation in encephalitis. CSF glucose is significantly low, especially in bacterial, TB and fungal meningitis. So it is normal or mildly low in encephalitis patient. So CSF lactate is increased more than 3.5 millimoles per liter in bacterial meningitis. So usually it is normal or mildly elevated in encephalitis. PCR detects bacteria or virus. So PCR is very crucial for encephalitis diagnosis, particularly HSV, enterovirus, autoimmune markers and all. If it is an autoimmune encephalitis. Imaging, okay, often normal unless otherwise they have some sort of effacement of sulci, leptomeningeal enhancement and all. So encephalitis usually temporal lobe involvement, very, very important. So for HSV, and they can have a cerebral edema. So EEG routinely not required in meningitis. So it's going to be abnormal diffuse slowing and periodic discharges in HSV encephalitis. Very, very important. Remember, okay. So which CSF tube to use for cell count analysis? So you can expect few questions in and around the procedure of lumbar puncture and how you are going to analyze the CSF sample and all. Okay, when it comes to analysis of the CSF count, so which tube you are going to analyze? So remember, so CSF, if you see tube 1, use it for glucose protein. So may be contaminated with the blood. Okay, so tube 2, go for microbiology, Gram-Stein culture and PCR. So tube 3 is the ideal thing for cell count and differential count, particularly RBC and WBC. So tube 4, if at all, if collected, so repeat the cell count. So in case of traumatic tap, okay. So tube 1 may contain blood contamination due to initial dural puncture. So tube 3 is more reliable for flow stabilizers by then. Okay, so that cell count is tube 3. If there is a traumatic tap, So comparison of tube 1 and tube 3 RBC count helps in assessing whether bleeding is iatrogenic or patient is having a subarachnoid bleed. Okay. So some practical questions you can expect. So can you comment on CSF lactate? So its use and its limitation. So nowadays we also follow CSF lactate analysis. So even if you don't send to lab, you can keep that sample in the ABG machine, then you are able to understand the CSF lactate. It gives some idea what's happening to the patient. Okay. So what is CSF lactate? So it produced in CNS by glycolysis under hypoxic or inflammatory condition. Why it is important? It helps in to some extent differentiate between viral and bacterial meningitis. So normal CSF lactate is less than 2. So typical in viral it's going to be less than 2.8 to 3. Typical in bacterial, it is going to be more than 3.5 to 4.2. So best diagnostic cutoff according to many studies is more than 3.5, which is having a sensitivity of 90%, specificity of 95% for bacterial etiology. Advantages. So it is rapid. We can do with the ABG machine also. So not affected by serum lactate. So unaffected by prior antibiotic also. So limitation, it can elevated in if patient is having severe hypoxia, stroke, subarachnoid bleed, TB, meningitis, convulsion, or if patient is having a mitochondrial disease. Okay. So does not identify the pathogen. So you need to exclude the other reason for raised CSF lactate. So when to use? When CSF gram stain or culture is delayed or ambiguous. So we can use for early triaging to categorize bacterial versus that of the viral meningitis. So not recommended when used alone without correlation with the other CSF parameters or the without having a clinical context. We can't just based on CSF lactate, we can't comment. So totally it is a bacterial meningitis. Okay. So next question, which are the common causes of bacterial meningitis in young adult? So it is given, okay. So 3 to 18 years, 3 months to 18 years, Neisseria meningitis, strep pneumonia, Haemophilus influenza. So 18 to 50 years, streptococcal pneumoniae, okay, Neisseria and Haemophilus. So more than 50 years, here comes we have an one more add-on organism, that is Listeria with Neisseria, streptococci and aerobic gram-negative bacilli. So immunocompromised host, so streptococcal pneumonia, Neisseria meningitis, so Listeria, monocytogenes, aerobic gram-negative bacilli. So intracranial manipulation, including neurosurgery, we can expect Staph aureus, coagulase negative Staph aureus, aerobic gram-negative bacilli, including Pseudomonas acinetobacter. So when we have a bacillar skull fracture, we can expect Streptococcus pneumonia, Haemophilus, and group A streptococci. So if you see, the commonest organism for community acquired pneumonia is going to be streptococci pneumonia. Very, very important. Okay. So, but you can go through this fantastic table to get an idea about the causes for bacterial meningitis. So, can you comment on utility of the CSF procalcitonin in meningitis? So, nowadays we have some data like CSF lactate. Some data is there in terms of CSF procalcitonin also. Some examiner may put this question. So, if you are thorough with some idea in this area, you can answer easily. Okay. So basically we have some systematic review and meta-analysis on the CSF procalcitonin in meningitis. So this is one 2018 data. So around 15 studies, more than 1,000 patients they included. Okay. So they included CSF procalcitonin alone. So pooled sensitivity of 80%, specificity of 85% for bacterial so meningitis as compared to viral meningitis. So CSF procalcitonin is a useful biomarker so which outperforms CRP but not a standalone replacement for culture or PCR technology. So again, one more 2021 data. So here meta-analysis of CSF biomarker including like procalcitonin, lactate and CRP. So CSF procal alone had good accuracy, but CSF procal with lactate provide a highest diagnostic tool towards the bacterial meningitis. So best utility is a part of biomarker panel, so rather as a single marker. So you don't use as a single marker. So the cutoff value used in many of the studies is 0.5 nanogram per ml. If it is more than that, which suggests towards the bacterial meningitis with a sensitivity somewhere around 70 to 90%, specificity of 80 to 95%. So again, it varies depending upon the population and the lab where you are going to have the assessment. So clinical application. So may help in differentiating bacterial versus viral. So when we have ambiguous cases, but it is always with the clinical context. So guide antibiotic stewardship. Okay, avoid unnecessary prolonged usage of the antibiotics in viral meningitis. So adjunct markers in post neurosurgical meningitis, like along with CSF lactate, so glucose ratio culture, we can give some weightage. So it also helps to some extent for monitoring the therapeutic like correlation. Okay, you started the therapy, a procalcitonin is decreased by some percentage, which tells like there is a response to therapy, particularly neurosurgical patients. Okay, so if they are having EVD or Ommaya reservoir, so you can send the CSF procalcitonin. Okay, and you can see the decrease in trend of the procal, so that it tells that your antibiotics are working in that particular patient. So remember this table. Okay, so next question, what are your immediate management steps? So including antimicrobial therapy and adjunct. So we have discussed your imaging modalities, CSF findings, differentiation between so your like encephalitis, meningitis, airway breathing circulation we assessed. Okay, so next is like what is the therapeutic approach. Okay, so here we started on an antibiotic, so immediately after blood culture, so ceftriaxone 2 gram IV 12th hourly, vancomycin 1 gram, so IV 12th hourly, dexamethasone, so 10 milligram IV we considered to give so before the first dose of the antibiotic. So acyclovir, here we are like having some sort of clarity, it doesn't look like viral, so then may not be required at this level when we have a narrow down with the image findings and all. So we admitted the patient for further monitoring and therapy in the intensive care unit. Okay. So these are the antibiotic selection and the duration in relation to the organism. So herpes encephalitis, okay, acyclovir, so 10 milligram per kg, 8 hourly, okay, for 14 to 21 days. So in bacterial meningitis, empirically, so ceftriaxone 2 gram BD plus vancomycin, so 10 to 15 milligram per kg, 8 to 12th hourly. So monitor the trough level in between 15 to 20 mics per ml is the target. So dexamethasone 0.15 milligram per kg, 8th hourly or 6th hourly daily for 2 to 4 days. So prior to or concurrent with the antibiotic, okay, particularly pneumococcal infection. So streptococcal pneumonia, if isolated, so then 14 days therapy, ceftriaxone 2 gram, so 12th hourly, okay. So or like 12th hourly plus vancomycin, so 10 to 15 milligram per kg, okay, when we have a suspected like ceftriaxone resistance with a MIC of more than 1, or patient is having a penicillin resistance, so with MIC of more than 0.12. Okay, so Neisseria meningitis therapy duration is 7 days. Ampicillin 2 gram 4th hourly, ceftriaxone 2 gram, so 12th hourly is another option. Okay, so Listeria monocytogen, it is an intracellular organism, particularly in immunocompromised patient or elderly patients, so who are more than 50 years, therapy for 21 days. So again ampicillin, okay, 2 gram 4th hourly. So gentamicin 5 milligram per kg per day for 7 days. So it is having a synergistic effect with that of the ampicillin. So or we can use trimethoprim sulfamethoxazole 5 milligram per kg 8th hourly if allergic to penicillin. So again, like some examiner might ask about post neurosurgery meningitis just for completion sake. So usually we have to target coagulase negative staph aureus, staph aureus, so or maybe gram negative organisms, carbapenem with vancomycin, or in a resistant case, we need to upgrade up to polymyxin, colistin and all. Okay. So tubercular meningitis, so INH 300 milligram in adult, that is 5 milligram per kg, rifampicin 10 milligram per kg, that is 600 milligram in adult. So pyrazinamide like 15 to 20 milligram per kg, maximum of 2 gram. Ethambutol 15 to 25 milligram per kg. Streptomycin in selected cases 15 milligram per kg per day intramuscular, maximum of 1 gram. A 4-drug regimen that include INH, rifampicin, pyrazinamide and either ethambutol or streptomycin for 2 months, followed by INH and rifampicin and ethambutol alone, okay, if isolate is fully susceptible, for an additional 10 months. So basically it's a 1 year therapy duration for TB meningitis. Very, very important table. So it summarizes everything. Okay. So what is the evidence behind steroid use in bacterial meningitis? Okay. So what you know, that may be your next question. So these are some of the studies So particularly there are good studies which got published in NEJM also. Okay. So Lancet, European guidelines. Okay. So they conclude, so dexamethasone early when we have confirmed or suspected strep pneumonia meningitis, we can give. So it is having some benefit in terms of overall improved long-term outcome. Okay. So the take home on steroid is whom to give: all adults with suspected acute bacterial meningitis, especially when pneumococcal disease is likely suspected. Okay. So when to give: before or with the first dose of antibiotic, ideally within 1 hour of arrival. If more than 12 hours after first antibiotic, benefit is uncertain. So dose 10 milligram IV adult dosage. So 6th hourly for 4 days. So commonly used alternative expression of the dose is 0.15 milligram per kg Q6th hourly for about 2 to 4 days. Okay. So continue or stop. So when to continue? If you have like diagnosed strep pneumonia, so continue for the full course, that is 4 days. So stop if non-pneumococcal pathogen is identified, or if meningitis is unlikely, no need to give the steroid. So outcome expected, it helps in reduction in unfavorable neurological outcome and mortality in pneumococcal meningitis, reduced the hearing loss overall, so limited or no clear mortality benefit in a low income setting. Very, very important. Okay. So mortality benefit in a good income setting, but there is no clarity on reduction in the mortality in low income setting. So that was the study on steroid. Actually, that is the original study. Okay. So if antibiotics already given before steroid, so benefit is less certain. Do not delay the antibiotic to give the steroid. Okay. So just give the antibiotic if too much time is consuming in giving the steroid. So special note, emerging observational data suggest so possible benefit even in Listeria meningitis, but we need more and more randomized control trial. So in using steroid for Listeria meningitis. Okay, so very, very important. So is there any role of rapid diagnostic which can support your diagnosis early? So in our patient also, we have sent the rapid diagnostics. There are lots of available tools in the market. So which gives an idea about the antimicrobial resistance also. We have agglutination test. Okay, fluorescence fluorescence in situ hybridization, so real-time PCR. Okay, so isothermal amplification, next generation sequencing, so laser desorption ionization, MALDI-TOF. So there are uh, some rapid diagnostic techniques are available. So if you see, the rapid real is going to be like fluorescence in situ hybridization, so isothermal amplification, and that of the real-time PCR. But agglutination, it is less than 5 minutes, but it is having its own limitation in terms of sensitivity and specificity. So PCR and sequencing based approaches are the most frequently applied modes of testing and suitable for the detection of organism with a gene which is responsible for the resistance from the that particular organism. And there is a varied in terms of like cost and the skill involved also. Okay. So what we got in our young gentleman, so CSF culture came as negative, that is a routine conventional culture. So blood culture is positive for strep pneumonia. CSF multiplex PCR also so detected the strep pneumonia. So basically this is the biofire film array which we sent, so which grown which identified strep pneumonia as an organism. Okay. So one good thing about like some multiplex PCR and all, if it comes negative for HSV, so it is negative for HSV, straight away we can stop the acyclovir. Otherwise what happens? So acyclovir is having its own problem, that of the nephrotoxicity. So at least you rule out, okay, there is no viral HSV, so you can stop the acyclovir in a particular patient. So blood culture, that is a strep pneumonia, this is the sensitivity report. So numerous like gram stain with a polymorphonuclear leukocyte seen, gram positive diplococci, that is a strep pneumonia. Okay. If you see, it is sensitive to ceftriaxone, which we already started, vancomycin sensitive. So it is sensitive to most of the lower grade antibiotic itself only. So this is the culture sensitivity we got in our young gentleman. So who is having strep pneumonia with so classical picture of the bacterial meningitis in the CSF. So next question is, what complication do you expect in a patient with bacterial meningitis? So what are the indicators or prognostic factors for the poor clinical outcome? So what are the complications we can expect? So if you see the overall complication, we can divide into early, late, okay, systemic, and there are specific group complications. If it like linked to the early complication, so couple of hours to day, so it is a sudden rise in intracranial pressure, cerebral edema, so convulsion which may lead to status epilepticus, cerebral infarction, stroke, hydrocephalus, acute hydrocephalus, brain abscess, subdural empyema. So hours to days, it is the early complication. Okay, so late sequelae, so they can have a hearing loss, so weeks to months and year. Okay, cognitive impairment, epilepsy, chronic like seizure disorder, so chronic hydrocephalus, so motor deficit, spasticity. So these are the late sequelae. So systemic complication, meningitis with septic shock. So they can have disseminated intravascular coagulopathy, particularly purpura fulminans in meningococcal meningitis, that is Neisseria meningitis. Okay. So because they are going to have a endotoxin secretion from meningococcal species. So they can have multi-organ dysfunction, hyponatremia, that is SIDH, which is more common. So septic arthritis, pneumonia as a secondary, so foci, so they can have, so all these systemic complications also. Special group, remember, adrenal hemorrhage, that is Waterhouse-Friderichsen syndrome with adrenal insufficiency in fulminant meningococcemia we can get. So in immunosuppressed patient, so they can have a recurrent meningitis, or they are more prone for opportunistic infection. So they need a further prolonged follow-up. So these are the complications of like meningitis. If you see, hearing loss is more common in strep pneumonia and so Hib meningitis, Haemophilus influenza meningitis. Okay. So if you see the prognostic marker, we have some clinical markers. So low GCS at admission, so poor prognosis. So convulsion, okay. So especially status epilepticus. So presence of shock, hypotension, septicemia, which leads to higher mortality. Signs of raised ICP or herniation, focal neurological deficit, like if they have a cranial nerve palsy, hemiparesis, so rapid progression of the illness within hours, within a day. So extremes of age like infants, neonate, low birth weight, elderly patients, so they can have a poor prognosis. So if they have comorbidities, immunocompromised like HIV, transplant, those who are on steroid, so they have a bad prognosis. So radiologically, if an imaging shows cerebral edema, infarct, vasculitis, hydrocephalus, subdural empyema or abscess, so they have a poor prognosis. So lab finding, okay, high protein more than 200, very low sugar less than 20, or like CSF to serum glucose is less than 0.23, high neutrophil count, so all indicate the severe disease. So high lactate in the CSF, hyponatremia, that is because of SIDH, coagulopathy. So pneumococcal meningitis, it's itself is having a worse prognosis than the meningococcal. So gram-negative bacilli meningitis is having a poor outcome, particularly in nosocomial meningitis in the neurosurgery patients or a trauma patient. Okay, so these are some of the prognostic markers in meningitis. So on day 3 in our young gentleman whom we started on ceftriaxone, vancomycin, and we given a steroid, so his GCS dropped to 8 from 10. So he got intubated. So his repeat vitals map is dropping, that is 30, heart rate is increased at 130, ABG shows acidosis with a lactate of 3.4 with a pH of 7.28, WBC from 22,000 it become 32,000. Okay, so this patient is getting deteriorated, so he got tubed. So basically in the next one more 24 hours, so his GCS dropped, okay, intubated for airway protection. So BP hypotensive like 86 by 54, MAP is around 60, tachycardia, so he started requiring norepinephrine. So on ventilator, his FiO2 is 50%, saturating 95%. So we kept a respiratory rate of 20. So urine output is bit low, 0.3 ml per kg per hour. So creatinine increased from 1.1 to 2.4, urea is 65. Okay, so hyperkalemia mild, sodium is 132, WBC 32,000. So CRP we got, it is 128, which is rising trend. So this is the ABG. Okay, as I already told. So lactate increased, it become 4.8 and pH is 7.28. So interpret this ABG. So examiner can give the ABG and he can ask So suddenly interpret this ABG. You should be aware of the stepwise approach to ABG. So acidemia is there. So PCO2 is 32. So respiratory alkalosis, there is some attempt for compensation. So with the background of primary metabolic acidosis with a low bicarb, so with a base excess of -9. So lactic acidosis, which adds to high anion gap metabolic acidosis. If you calculate anion gap, it is 16. So is little bit elevated creatinine and high lactate explain the high anion gap. Oral interpretation, high anion gap metabolic acidosis due to lactic acidosis with partial respiratory compensation. So patient now is having a sepsis with septic shock, acute kidney injury, metabolic acidosis with high lactate. Okay. So this is in and around third to fourth day. So he started deteriorating on mechanical ventilator. Okay. So, so do you feel like we need to do an MRI at this stage when patient is having a drop in GCS and all? What are some specific indications for like MRI, or when you consider to do CT, when you consider to do MRI, okay, in a patient with meningitis? So basically, MRI is not routinely required in all meningitis. So initially, like when LP is contraindicated for suspected raised ICP or focal deficit, when there is a poor response to the antibiotic. So we started our patient on antibiotic, but there is a poor response. So when complications are suspected, you are suspecting some infarct, hydrocephalus, so abscess or vasculitis, or in case of TB or fungal or post neurosurgical, or if a patient is immunocompromised, so then we can get the MRI with contrast. Otherwise, not routinely. So our patient is deteriorating on antibiotic, we can think about getting the MRI. So this table gives a fantastic idea. So best imaging in terms of CT versus MRI, maybe MRI with contrast, MRI with diffusion weighted image, MRI angio. Okay. So in relation to the suspected complication, we can choose the modality of image also. You can just go through this table quickly. CT versus MRI, when to consider, which one to consider. Very, very important practical aspect. Okay. So how will you further manage? So what about vancomycin? See, we got our patient like blood culture is strep pneumoniae, CSF on multiplex PCR. It is like we got it as a like strep pneumonia, again biofire film array. If you see, the sensitivity is sensitive to strep ceftriaxone and vancomycin. So should we continue vancomycin in our patient because it is a strep pneumonia which is sensitive on paper? So here is the summary. So further plan, continue the ceftriaxone because we isolated an like sensitive strep pneumonia, so which is having a ceftriaxone is having a very good CSF penetration. Vancomycin stop because patient already having some sort of acute kidney injury, okay, and we have a sensitive bug, no need for vancomycin. So steroid continue for 4 days, that is a part and parcel of your strep pneumonia. So consider broadening the spectrum. So if clinical suspicion of secondary sepsis like maybe VAP, so CLABSI, urinary tract infection, better to escalate to one ESBL coverage, that is a carbapenem. So patient is having a rising count, that is 22 to 32,000 it becomes. So shock not always from the meningitis progression. We need to think about other like complication at this level also. Day 4, day 5. Okay. So other nosocomial infection. So in a patient with pneumococcal meningitis, so confirmed to be ceftriaxone sensitive. So we would continue ceftriaxone as a monotherapy, stop vancomycin to reduce the nephrotoxic risk. So again, so day 3 deterioration, day 4 deterioration. So maybe secondary nosocomial infection is the cause here. So we consider to broaden the spectrum. So that is the rationality. So we started on the meropenem. Suppose if you add meropenem at this level, so will you continue ceftriaxone? Is it necessary or we can stop it? So answer is, remember, meropenem can cover pneumococcus, but it is not a standard or a preferred agent in ceftriaxone sensitive strep pneumonia. So it is mainly reserved for beta-lactam allergy, a resistant isolate or nosocomial gram-negative meningitis. In this patient, meropenem would be added only for secondary hospital-acquired infection coverage, not for primarily for treating the meningitis treatment. So better to continue ceftriaxone and keep meropenem, so particularly for the coverage of other nosocomial organism. Again, So this is about meropenem, vancomycin and ceftriaxone. So what we discussed, everything is in this table. You can just go through this table. Okay. So in the next day 5, 6, 7 in the ICU course, so patient is on ventilator, his FiO2 requirement increased to 65 to 70%, is on PEEP of 8. So X-ray shows left-sided infiltrates, okay, with minimal infiltrates in the right side. So most likely, so he started having a ventilator-associated pneumonia, new onset of fever, rise in WBC count, okay. So we send the tracheal aspirate, so which grown Acinetobacter, okay. So this is the culture sensitivity report. If you see, it is sensitive to polymyxin B, okay, that is intermediate to colistin, minocycline sensitive, so tigecycline, so it is a variable sensitive. But if you see, it is resistant to meropenem. What is your approach at this level? Okay, so patient was on ceftriaxone, we added meropenem, like thinking about nosocomial infection, but he got an Acinetobacter, which is an XDR. So only retaining a sensitivity to like polymyxin colistin and so minocycline, so tigecycline. It is a carbapenem resistant organism. So what is your agent of choice at this level? Okay. So obviously, so we have stopped already vancomycin. So we are going to stop meropenem because this Acineto is mero resistant. So continue ceftriaxone for meningitis for the entire duration of 10 to 14 days of course. So for MDR, that is XDR Acinetobacter in VAP, so polymyxin B IV loading dose plus like 15 lakh loading dose followed by 7.5 lakh IV BD. So then subsequently you can consider to adjust the dosage for creat clearance if patient is stable. In an unstable, don't bother about adjusting immediately. So we can think about nebulizer colistin as an adjunct. So you can give IV polymyxin with nebulizer colistin, but recently IDSA is putting not a very good weightage for nebulized antibiotics. So minocycline, always use it as a combination therapy, 200 milligram stat followed by 100 milligram IV BD we can give. So polymyxin B is preferred over colistin because it is a good against Acinetobacter, better PKPD profile because it is not a pro drug like colistomethate sodium. So less nephrotoxic. Okay, so we can give loading dose and a maintenance dose depending upon creat clearance later. So inhaled colistin or polymyxin as an adjunct. So we can give with a systemic therapy always, not as a standalone nebulizer therapy. Okay. So, but we need a ultrasonic nebulizer or vibrating mesh nebulizer, not the bronchodilator delivery jet nebulizers. Very, very important. Okay. So, minocycline, it is active against Acinetobacter, but always use as a combination therapy with polymyxin where it is having a synergy. Tigecycline, we can consider. So, but lung pharmacokinetics is variable. So, not preferred for bloodstream involvement when we are dealing with the VAP with the bacteremia. Okay. So maybe better option is polymyxin B with minocycline SOS as a synergistic combination. Okay. So other ICU supportive care, what you need to see. This is one common question you can expect in any of your diagnosis. Okay. Head and elevation, maintain normocypnia, normoxia. So electrolyte balance, particularly they are more prone for hyponatremia secondary to SIDH. So glucose monitoring, DVT, stress ulcer prophylaxis, keep a maintain adequately. So consider ICP monitoring as one of the modality if GCS is less than 8 persistently. So as early as possible, enteral nutrition. These are all other ICU care what we need to do, like another patient we need to do in this ventilated meningitis patient also. Okay. So next one important thing you might get is what isolation precaution, like it is the transmission specific isolation because there are specific isolation needed particularly for Neisseria and all. So if it is a Neisseria meningitis, so we need a droplet precaution. Okay, so it is most important. So other bacterial causes like strep pneumonia, hemophilus and all, standard precaution generally adequate. So TB meningitis, we need a airborne precaution if there is a pulmonary TB suspected. Viral meningitis or encephalitis, so enterovirus HSV, okay, we need contact isolation and standard precaution depending upon the virus. So core ICU precaution we need to take is like surgical mask for the staff in terms of droplet precaution. Visitors within 1 meter of distance, definitely they need a surgical mask. So single room isolation wherever it is possible. Glove, gown, hand hygiene for all patients. There is a contact isolation. Airborne isolation, N95 mask we need only for varicella zoster or TB meningitis patient with a pulmonary TB suspected. So duration of precaution. So meningococcal meningitis, remember, so maintain droplet precaution until 24 hours after effective antibiotic therapy. Other bacterial meningitis, so we can consider standard precaution until clinical stabilization. Viral causes depends upon like enterovirus. Until diarrhea is going to resolve, we need a proper contact precaution. So additional preventive measures, so chemoprophylaxis for the close contact of Neisseria meningitis, that is meningococcal exposure. So better to consider rifampicin, ciproflox or ceftriaxone so as a chemoprophylaxis. Then vaccination strategy. So if there is an outbreak or high risk exposure, we can consider for vaccination. So these are some of the add-on questions where you can expect when your viva is in and around the meningitis patient. So what is the recommended duration for antibiotics for streptococcal pneumonia? Meningitis, it is around 10 to 14 days. Okay, so can extend up to 21 days in a complicated cases. So in our patient, so is hemodynamically stabilized on further therapeutic continuation. So vasopressor weaned off. So fever subside by day 10. So he's been extubated on day 14. So in another next 3 days, he's been shifted to ward, that is on the day 17. So this is a simple flow chart for therapeutic option for meningitis. If patient is having a fever, headache, neck rigidity plus or minus altered sensorium. So if he is having obtundation, okay, uh, like focal neurological sign and his immune system is compromised. If answer is yes, get a image, either a CT or MRI before lumbar puncture. So okay, so otherwise like we can proceed with the lumbar puncture, then obtain the blood culture. In CT, there is no mass effect or posterior fossa mass, then go for the LP. If there is a concern about the mass effect or like posterior fossa mass is there, no lumbar puncture, so empirical antibiotic coverage we can give. So then we can consult the neurosurgeon. Okay. So like once you done lumbar puncture, when you don't have a mass effect and all, so begin the empirical antibiotic coverage. So maybe started 4 hours prior to lumbar puncture if procedure cannot be done immediately. Okay, so then therapy is vancomycin, ampicillin when you have a suspected listeria, so dexamethasone when you have suspected strep pneumoniae. Okay, so then monitor for hydrocephalus, seizure, DIC, SIDH, venous thrombosis. So if it is a viral thing, acyclovir. So stop acyclovir if your PCR is negative. Monitor for further therapeutic improvement. Okay, so this is an overview on the schematic representation for meningitis management. So these are some of the high voltage questions you can expect in your case based discussion on meningitis. So we'll come back with many more case based discussion. Till that time, so revise, recall, practice at the bedside. Very, very important. Thank you.